to the first speaker for the day and the star for the night today. This is from Pakistan, and this is one of the most lovely country to my heart. This Professor Fauzia is Professor of Anaesthesia in Aga Khan University, one of the biggest universities of Pakistan in Karachi. Professor Fauzia Khan was a previous head of Department of Anaesthesia. Now she is a professor and a big professor in the university. And she got her training, primary training from UK. She published more than 160 articles for that. She received a Research Productivity Award from Pakistan Scientific Council for her marvelous work. She chaired the Safety and Equality of Practice Committee of the World Federation of Societies of Anaesthesia. Now she's a member of the committee, still using her experience. Again, Professor Fauzia, her current practice of interest in anesthesia is pediatric and neurosurgical anesthesia. Welcome, Prof. Fauzia. We are ready now to learn from you your knowledge about perioperative mortality. The floor is yours.
Thank you very much, Dr. Yasser, for the introduction. And I would like to thank the administrators for asking me to be part of this group and to deliver this talk. So I'm going to talk about perioperative mortality. I have no conflict of interest, but as I've said, I was former chair and I'm a current member of the Quality and Safety of Practice Committee of the World Federation of Societies of Anaesthesiology. So what I intend to do in the next 30 minutes or so is to talk about the value of mortality studies in anesthesia. Why should one gather this data? What do we know so far? What are the problems of interpreting this mortality data? What is the classifications that are being used? I've looked at some systematic reviews and I'll present them. What to do if a table death occurs? How to conduct a mortality meeting, and lessons learned so far, and what next. So why gather this data? Why are we interested in perioperative mortality? Now, 1/3 of the global burden of the disease is related to surgical conditions. And over 300 million surgical operations are performed annually worldwide. And almost 4 million or more are estimated to die within 30 days of surgery. So even a small reduction in perioperative mortality will save thousands of lives per year. So what is the value? Firstly, to identify avoidable causes. Then the assessment of safety of service can be concluded. Also to review trends, to help identify system errors, and to formulate strategies to prevent these errors. And then one can get directions for future research. One other reason is the Lancet Commission for Safe Surgery, especially in LMIC. They have identified 6 core indicators for countries to look at so that safe surgery can be provided to lower and middle income countries till 2030, by the time of 2030. And one of the indicators is perioperative mortality rate. So what do we know so far? Anesthesia mortality has been a surrogate measure of anesthesia safety for the last nearly 100 years. Historically, it was in 1893 that the Commission on Anesthetic Deaths was established. And then in 1954, this was the first morbidity and mortality study, which was by Beecher and Todd, which was published in 1954. And they looked at 384 anesthetic deaths in 600,000 anesthetics from 10 university hospitals over a period of 5 years. And 80% of the errors of anesthetic techniques and choice of management were identified. Over the next couple of years, there were quite a few studies which were published from different countries like South Africa, Canada, from UK, from France, from Sweden, and they looked at anesthesia-related mortality. And there was a lot of variation in the results that were published. There were also studies from Japan, Thailand, France, and Brazil. But over the past 2 decades, most of the published studies have reported anesthesia-related mortality rates ranging from 0.5 to 1 per 10,000 anesthetics, or even lower, which is at least a 10-fold improvement from the time when these studies were started to be published. Now, most of the literature that has come is from high-income countries. In 2012, Bainbridge and his colleagues, they published in Lancet, and they looked at all studies which were published up to February 2011 in any language, with a sample size of over 3,000. That reported perioperative mortality across a mixed surgical population who had undergone general anesthesia. So these were studies both from high-income country and low-income countries. Sorry, what's happening? Okay. Now, this is from the same study. This is a diagram which shows the number of studies and their size in relation to each other over these years. There's data of nearly more than 50 years present here. What they concluded was that the decline was greatest in countries with high development index, whereas anesthesia-related mortality was 2 to 3 times higher in low middle income countries, though there was a decrease in mortality, but this was still 2 to 3 times greater. So let's look at the problems in interpretation of data from these studies. One problem is, what is the definition of perioperative death? Is it just intraoperative death? Is it death in the operating room and recovery room? Is it the first 12 hours? Is it the first 24 hours, the first post-operative week, or the first post-operative month? Because different studies have looked at different periods. Some of the authors have pointed out that even 30 days is not enough to look at perioperative mortality. And they recommend a period of almost 90 days, because they say that the care and the risk does not end at 30 days. And death can occur after 30 days, which is still related to surgical mortality. There were these 2 studies published in Annals of Thoracic Surgery, who looked at the 90-day mortality and the 30-day mortality, and they found out that the 90-day mortality was almost more than double than the 30-day mortality. So the problems, first of all, there's bias on those who are interpreting that data. There may be incomplete information, because there is retrospective assumption. There is also hindsight judgment by the people who are looking at this data. Then there is interplay of multiple factors, which is very difficult to differentiate. And there is lack of risk stratification. And in many of the published literature, the denominator is unknown. Discussion of causes and risk factors is limited to a wide range of ages. People have included children, older age group, middle-aged patients in these studies. And then another problem is that the anesthetic drugs and the anesthetic techniques have changed over the years. If you looked at the data of the last 30 to 40 years, so many of our drugs have changed, and there have been newer techniques that have been introduced. All anesthesia reporting is subjective to some extent. And the estimated rates, they depend on the definition used and the accuracy of numerator and the denominators. What about the classification of perioperative deaths? People have classified these deaths differently as well. Did the anesthetist make an error? Was there an anesthetic reaction involved? Was there equipment failure? Was there human error involved in the causation of event? Or was there a human error involved in the management of the effect? So many different ways. Another way is to look at whether anesthesia contributed solely to the perioperative death, whether anesthesia was predominantly cause of the perioperative death, or was it both the anesthesia and the surgical factors that were involved, or was it anesthesia did not play any part? One of a good classification, one of a good classification that I've come across is the Anesthesia in New Zealand College of Anaesthesia classification. What they do is one of a good classification that I've come across is the Anesthesia in New Zealand College of Anaesthesia classification. What they do is they classify the deaths, they classify it into three categories. One is the death attributable to anesthesia, death not attributable to anesthesia. Out of the deaths attributable to anesthesia, the category one is when the person or the committee who's looking at these deaths is reasonably certain that death is caused by anesthesia or other factors under the control of the anesthetist. Second category is if there is some doubt that death is caused by anesthesia or other factors under control of the anesthetist. And third category is when the committee is reasonably certain that death caused by both anesthesia and surgical factors. The next group that they recommend, by the way, these are deaths that occur within 24 hours. That's the definition that they take. So deaths not attributable to anesthesia are where anesthesia is not contributing and other surgical factors are implicated. And the fifth category is inevitable death, that death would have occurred irrespective of anesthesia and surgery. And the category 6 is incidental death, which was not foreseen. The third group that they classify is unassessable deaths. These are deaths which cannot be assessed despite data, or deaths that cannot be assessed due to inadequate data. So moving forward, I've looked at some of the systematic reviews that are present on perioperative mortality. And as I'm sure you may be all aware of, the levels of evidence that are currently taken, systematic reviews are on the top of the level of evidence. This was a study from Brazil, which was published in 2009. Braz and his colleagues looked at Brazilian as well as worldwide literature, and they evaluated the incidence and causes of perioperative and anesthesia-related mortality. And they looked at studies between 1954 and 2007, and they assessed 33 trials. Now, what did they find? There was substantial difference in the methodology, and the studies suggested that anesthesia mortality has decreased, and they identified high-risk population, which were neonates, children less than a year, elderly, males, ASA3 patients and above, and those who received general anesthesia. And the surgeries identified were cardiac surgery, thoracic surgery, vascular surgery, GI, pediatrics, and orthopedics. This was another systematic review that was that focused on pediatrics this time. And they found 8 articles on mortality in the first year of life from different countries. And their key findings were, these were publications from many different countries all over the world, the 8 countries. But again, they found that the timings were different. Some had taken 7 days, some had taken 24 hours, some had taken just operating room and recovery. And therefore, the incidence per 10,000 anesthetics varied extremely. What were the key findings? They found a higher incidence of mortality and morbidity in children under 1 year of age compared to older children. They also found an increase in the incidence in the neonatal period, and there was high frequency of cardiac arrests in patients under 1 year of age. So what they said was there is lack of studies which centered on neonatal period and the 1st year of age, and there was great variability of methodology for the study of the same concepts. Cronje from South Africa, they published in 2015. This was also a review of pediatric anesthesia-related mortality, but they did it a little differently this time. They looked at the high income, the middle income, and the low income countries separately. And if you look at the red box that relates to 24 hours anesthesia-related mortality in children, and what they found that was in high income country, the rate was like 1.19 per 10,000 anesthetics. In middle income countries, it was 2 to 4 times more. But look at the low income country figures. They were 37 to 60 per 10,000 anesthetics. So the world became aware that the perioperative mortality was much higher in low income and also in middle income countries. This was a review that was published in Cochrane database, and this looked at the neuraxial blockade for the prevention of postoperative mortality and major morbidity. And they concluded that compared with general anesthesia, a central neuraxial block may reduce the 0 to 30 days mortality for patients undergoing surgery with intermediate to high cardiac risk. And they again said that further research is required. Now, Landoni et al., they published a web-based international consensus conference that was held between 1,000 physicians from 77 countries. So this review, they followed a different methodology, and they looked at articles concerning interactions which influenced perioperative mortality. And they identified 14 interventions suggesting that they influenced perioperative mortality in adult surgery. And this included use of insulin, clonidine, intraoperative balloon pump, and volatile anesthetics, neuraxial anesthesia, non-invasive respiratory support. Some countries have looked at their mortality reports. They've reported their mortality from time to time. For example, Australia does that. They publish their triennial mortality reports. And I think UK does that for maternal mortality reports. This is an example from a paper published from Australia, who looked at the data from their 8 anesthesia triennial mortality reports between 1985 to 2008. And they found a substantial decrease from 85 to 2008. It fell from 1 in 36,000 anesthetics to 1 in 55,000 anesthetics. So the key findings were that anesthesia-related mortality is about 1 in 50,000 anesthetics in the Australian continent. And there was a need to focus on non-preventable deaths considered to have no correctable factors with the current state of knowledge, drugs, and techniques. And additional efforts were required to further reduce preventable anesthetic deaths. This paper has been published about 2-3 years ago, 2018. They used another methodology of a scoping review, and they looked at nearly 10,000 publications, and they identified 15 interventions Out of this, 7 themes had a significant effect on mortality. And what were these? There was pharmacotherapy, nutritional status, use of transfusion, ventilation, glucose control, use of medical devices, and dialysis. So what they said, that they have identified areas which require further systematic investigation. There is still lack of consistent and reliable data from lower and middle income countries. One of the first landmark studies in this respect was from Thailand, who looked at their perioperative death in 2005 and gave us their rates. This was a study which we did a couple of years ago in my institution, but this is just limited to our institution. And again, we looked at mortality in a teaching hospital department, and gave our figures on partially related mortality and anesthesia direct related mortality. This is another paper which we've recently published in Anesthesia and Analgesia. But in addition to mortality, we primarily looked at major adverse events which led to anesthetic morbidity and mortality. And what we found was that infants, especially those with the congenital heart disease, they were identified as a higher risk for a perioperative cardiac arrest. But this association was not tested statistically. And interesting was that 28% of the patients who suffered events, they died within 48 hours. Another paper from Brazil, this was published in 2016, and they looked at an 8 years observational survey, and their mortality rate was 16 per 10,000 anesthetics. But they mentioned that there was no anesthesia-related deaths where anesthesia was solely responsible. So this is another study which has been published from Kenya in 2017. Again, they've given their rates of 24 hours mortality, 48 hours mortality, and 7 days mortality. And the highest mortality seen were in general surgery, orthopedics, and neurosurgery. And emergency surgery had the highest mortality. I'm not going to go into the details of maternal mortality because that's a subject on its own. So what does one do if a table death occurs? Because this is a catastrophic event for any anesthesiologist, but one does come across it once or twice in their lifetime. I've just put a quote of Professor Atkinhead there, who says, we got into medicine because we value life and because we want to save people. What do you do when you can't save that life? How do you deal with that emotion? Unfortunately, this is something which we are not taught in our at least in our country, in our medical curriculum, or in our postgraduate programs. This is a good paper that appeared in the Continuing Education in Anesthesia, Critical Care and Pain, which accompanies British Journal of Anaesthesia. And they've identified different areas which should be taken care of, or strategies of handling the aftermath of an intraoperative death. First of all, the record keeping, they say it should be meticulous, and all records of preoperative check, of drugs, of type of anesthesia, of all the personnel involved, the fluids, and the procedure should be kept. And the involved anesthetist, that's important. Though the patient who dies is the first victim, but the involved anesthetist is the second victim. So there can be short-term sequel, or there can be long-term sequel of after an intraoperative or a table death. The second victim is the anesthetist, but there's a third victim as well. Third victim is the patient that that same anesthetist is going to anesthetize the next time or on the list. So some recommend that resting period should be given in between after such an event occurs. And then departmental support to such a person or the persons involved is very important. Again, breaking bad news to the family. It is recommended to be honest, straightforward, and sympathetic. It is also recommended that the anesthetist involved should meet the relatives together with the surgeon. Then the subsequent actions, the documentation should be fast. The relatives, if they want to pay respects to the patient who's died, they should be provided that. And then lastly, the team debriefing. There is no consensus on how to do this, but there are several techniques that are recommended. And it is recommended that this should be done as soon as possible. And this is different from the mortality meeting that takes place afterwards. One of the techniques that is recommended is the biceps model, which tells you how to organize this. And these, as I said, there is no consensus on debriefing, but these are based on critical incident stress management programs, which have come from soldiers who come across traumatic events in the army. So how does one conduct a mortality meeting? Well, setting a stage is important. Department should have good interpersonal relationships, and the culture should be non-punitive, and there should be transparency in conducting these meetings. The goal, it should be emphasized, is to learn and to avoid mishaps from happening in future. The activity must be integrated in the normal management of a unit or a service or a department, and there should be a team with a team head who should be responsible for organizing and coordinating these meetings. The team head may not be the most senior person, but he or she should be senior enough so that she or he has respect from the peers. And a time schedule should be agreed upon, the duration of the meeting, the frequency leading to a yearly calendar. And the dossiers must be carefully prepared, defining who is in charge of the preparation and the presentation and what documents are to be presented. It should be preferably multidisciplinary, involving the other disciplines that were involved in the surgery. And the questions that need to be asked are what happened, why did the accident happen, and one should search for immediate causes like active factors, but also for the latent factors which resulted in these in the mortality, and what improvements can be done and how it can be prevented in the future. In addition to that, the facilitator must ensure the relevant questions and must discourage fault finding and encourage contributions from all participants. And the discussion should be constructive, and value should be given to different opinions. And of course, the recommendations, there should be some recommendations and the outcome. This is the Ishikawa's diagram, or the fishbone diagram, just given as an example of finding the active factors and the latent factors that are involved. So if an anesthetic equipment failure has occurred, there may be many other latent factors which may be responsible for that, like the work environment, staffing, skill mix, technician support, patient factors, or anesthesia equipment factors. And a follow-up of the mortality meeting must be done, and means of addressing the process and system failures. And the solution should be smart. It should be specific, measurable, achievable, relevant, and timely. So what are the lessons learned from perioperative mortality, and what should be the next step? The incidence of death related to anesthesia increases with increasing age. It increases with the increasing ASA status, with the complexity of surgery, with emergency surgery, and mortality is higher with general anesthesia versus regional anesthesia. Human errors plays a major role. System error should be the one that should be targeted. The cardiovascular and respiratory management and inadequate monitoring are present in a large number of cases, and also inadequate preoperative preparation. So anesthesia-related mortality has decreased over the past 2 decades, but the decrease is more pronounced in high-income countries compared to low-income countries. And we need to go beyond the counting of anesthesia mortality, and we need large multi-centered randomized studies to identify specific subsets of patients in order to minimize confounding factors and biases. So a number of recommendations: how can anesthesia safety be improved further? Adherence to safety standards, equipment with modern safety features, structured systems to analyze problems, and institute remedies to prevent recurrence. This is another interesting paper. It's in fact a systematic reviews about use of definitions of perioperative mortality and low and middle income countries. And what they stated was, though, that it's reported in many countries, but a quality assessment checklist for mortality studies should improve mortality reporting and facilitate benchmarking, as there is a wide variation in literature. So I'm going to end my talk by something again that was written in the Australia and New Zealand Safety of Anaesthesia report. What they say is many anesthesia-related deaths are potentially preventable, and these could be further reduced by continuous improvement in training, in medical education, and increased allocation of specialist anesthesia resources. However, there remains a component of anesthesia-related mortality deemed not preventable in the current status of knowledge, and the pursuit of no death attributable to anesthesia therefore requires further research into safer drugs and techniques. So thank you very much, and thank you for patient listening.
Thank you, Prof. Fauzia, for this fantastic presentation. I like it. And you speak first about the incidence and variation in incidence according to study, because there's many factors affecting that, and perioperative mortality definition, and a very big varieties of definitions, even lead to different statistics, and how to count the problem and the classification of the problem, and drug affecting some drugs like oxygen, as you said, may increase the mortality. And the last presentation was Dr. Sahel about that. And also some classified people, which increased as a people, pediatric patient, extensive surgery can affect the mortality and the outcome. But really, mortality may be just a number for us as a anesthesia doctor. But for a human being or for a person, it is not a number. So a very low number is a very big problem affecting the patient, family, even a doctor. You know, the other day I read in Facebook, one of our colleagues, he make an anesthesia for appendix, and the patient, for unexplained reason, arrested and died. And he stayed about 45 minutes, and even everyone helping him, leave him, is still insisting to resuscitate. And he at the end, he asking Allah, all the reason for the earth is finished, but the patient is young, have a kids, and if she die, I will die. And you know, fortunately, and he gave a picture for the patient survived, put in the ventilator after 44 hours, and he said that the patient survived. So it is not just a patient, but he said in his topics that now he's scared to make an anesthesia for appendix, and still he's not normal, and he's scared to make anesthesia for the same place, as Dr. Fauzia said. So I'm just, you know, if I have a question, you can put it in a question and answer mark. But I have a very, you know, that most of a simple question, but it happened mainly in practice. You know, in many cases, the patient don't have any increased risk. The patient 25 years old is normal and don't have a problem. and sometimes the patient all of a sudden arrested or died, and sometimes he very resist to return back. And at the end, with even mortality and morbidity, you can't find a reason and put a differential diagnosis. And in some area, you can't make a distinction for the body, for cadaver. So you don't know. How can you deal with this, such as this events in your practice?
Yes, that's the reason, that's why it is being recommended that we look at those mortalities or perioperative deaths where no reason has been found. And the need to look at smaller groups of patients, like, for example, just with a certain type of cardiovascular mortality or with COPD, or the answers will become more clearer if we have that kind of information. Otherwise, there are a lot of things, lot of factors which are intermingling with each other. That's why I like that anesthesia and the New Zealand College definition, because in their classification, they have put this category as well, where you don't have any reason, where you don't find any reason.
Thank you for your answer, Prof. Fauzia. One of our colleagues, I think you see that in your presentation, but I think Dr. Sabir want to insist about that. He said, asking you, how can we, in anesthesia practice, how can we decrease our mortality in anesthesia practice by simple words? Just advise us by simple words about how to decrease it.
Simple words, I think we have to be, true to ourselves, and we have to justify ourselves that we have looked at our patient in the preoperative period. We are convinced that all that could be done for the patient has been done in the preoperative period to give them the best chance. Then again, do our best, because, in lower middle income countries, we don't even have all the anesthetic equipment and all the drugs available to us. But whatever is available, we should use according to our knowledge, and we should apply that knowledge and also follow our patients in the postoperative period. Many anesthetists just take their responsibility in the intraoperative period, but I think they forget the preoperative and the postoperative period, that they're important as well.
Another two questions from my colleague, Dr. Mohammed Sulaiman. He said, what should advise about the content taking related to the issue? I think he need to ask about, will be tough, a little tough for the consent to explain everything, even a very remote problem, or what do you think?
Yes. Sorry, I did not understand the question.
Yeah, question, he said, do you think you must be a tough with the consent permission to discuss for the patient everything, even the very little problem can happen, and remote problems in our consent or not?
No, I think that's very difficult, because there is limited time. It has to be a generic consent, which everybody agrees on. Usually departments agree on a generic consent. If you start telling every patient that you will die during anesthesia or due to anesthesia, nobody is going to come for surgery then. So, it's like, when you talk to the patient, I think it's best to tell them that, look, the risk of death is there when you cross the road in traffic. It's much, 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 much less. Anesthesia now, it's much safer now. So but if you're looking at a particular, for example, anesthetic technique, then it's best to tell them 2 or 3 major things, but not each and every minor detail.
Thank you, Prof. This is the last question for the time. Also, Dr. Mohammed Sulaiman, do you think that rapid support team can help if the situation going wrong, especially, I think he mean help for the patient outcome and also for the supporting our colleague?
A rapid support team is for perioperative death?
Yeah. I think he mean our colleague, as you said.
Yeah, of course. Of course, I don't think so. There should be any shame in asking colleagues for help. Even at a senior level, one should not make it, something which should not be done. The more senior you are, you shouldn't ask. We always call for help within our department. There is a serious event that occurs. And of course, if a perioperative death does happen, then I think the support of the department and the support of the colleagues is very important.
Thank you, Prof. Fauzia. And because of the time, we need to listen for you all the night. But unfortunately, because we have a limited time, even on YouTube and Facebook,